Hello, everyone. Welcome to the Taking Control of Your Diabetes podcast. I'm one of your two hosts, Dr. Steve Edelman, and unfortunately, my good friend and colleague, Dr. Jeremy Pettis, is not here today with hunkered down with childcare issues. And we are both endocrinologists. We both live with type 1 diabetes, diagnosed at the age of 15. We work at TCOID, and we also are very much in tune to educating folks living with diabetes as part of the not-for-profit organization. So today, I have a good friend and personal retinologist, I can call you, Nik, Nik London, who is an ultimate ophthalmologist specializing in the retina and other areas, and does take care of myself and so many of my other patients. In fact, I've sent him so many referrals. He's put all three of his kids through college.
Thank you, Steve.
Well, you will. Nik is the father of three boys. So, Nik, before we get into the questions, say something about yourself. So that people know who they're listening to.
Yeah, thanks, Steve. What a really kind introduction, a little over the top, and I appreciate it. But I expect nothing less from you. It's an honor. You know how I feel about helping you out with these events. It's an honor to be here. I love doing this. I personally love educating patients as well. I try to do as much as I can with chair time in the room individually, but on a broader level, I mean, these events are fantastic, and just you should be so proud of yourself for doing this for so long. I mean, it's amazing the difference you've made in the lives of your patients and thousands of others who learn from this. So it's an honor. So about me, humble beginnings, bounced around in life from the Bay Area, grew up in Ohio, went to UCLA for college, go Bruins, and then Cleveland Med School, and was lucky enough to train at Wills Eye Hospital in Philadelphia, which is really a really great retina training program. And now I'm in San Diego, so I'm the president and CEO of a practice called Retina Consultants San Diego. Really wonderful group of 4 docs. We take a ton of pride in providing the best care we can to our patients, evidence-based. We do a lot of research, a lot of clinical trials. We're very plugged in. We go to all the meetings. So we really try to bring that top level care and cutting edge stuff to patients, and as well as to these events where I can hopefully talk about some of these things that are ongoing. But that's enough about me.
Well, Nik, I just got to say that, you've helped us out when we did face-to-face conferences, and we have 2 excellent videos in our video vault that Eric, our producer director, who's also on the line and sets up these podcasts. I remember the first visit, I went to the office and took people through a regular office visit when they're getting their eyes checked, and then we did another one on eye care. So you've always been very generous with your time, knowing how crazy busy you are. Okay, well, let's just open it up with a general question: is why is this topic of eye disease so important for people living with diabetes?
It's a great question. So eye health is just of paramount importance to patients living with diabetes. You can't really stress enough the importance of vision to this group of patients. These are people that are driving, working, taking care of their kids. I mean, there's the impact of vision loss is really profound in this group. So the idea of eye health and eye care is just important from that perspective. And it's the good thing here is that a lot of this is preventable. Any damage that can develop in the eye and the retina, for the most part, is treatable or preventable with proper education, proper management of diseases and pathologies if they do develop.
Yeah, Nik, education is so important, and awareness. And, I think there's not a single person who has diabetes on this planet that doesn't think about what we've been hearing about since we got diagnosed, losing your vision, going blind, losing a leg, getting on dialysis or needing a transplant, and having heart problems. So it's one of the things that people think about. And as a person who has had diabetic retinopathy and macular edema, which we'll talk about, it's one of those complications that is there every minute of your waking day as long as your eyes are open. When you go to sleep, obviously your eyes are closed. So it's not like some other complications like kidney disease where you don't feel any different most of the time and it's not right there in your face. But I know there's some pretty scary statistics on people with diabetes who develop visual impairment or, I hate to say it, who go blind, and this does occur. One of my big fears, but thanks to you and the rest of your team, I feel pretty confident that's never going to happen as long as I come to my regularly scheduled visits. But give us some statistics. I know it may scare some folks, but I think it's important to talk about.
You know what, Steve? Statistics do change over time, and there absolutely are scary statistics out there, but I really don't, personally, I don't focus on those. And I'm not, as a retina specialist, people are sort of triaged to me. So I see like the pathology. I see the cases that usually need treatment or need reassurance at the very least. So I don't see the broader population, and am not as familiar with the overall statistics, but they changed over time. So I think several years or even decades ago, there was a fairly high incidence of patients over time developing vision loss due to diabetic macular edema or diabetic retinopathy. And in cases where we don't intervene, that's still definitely the case, right? If you're a patient with an A1C of 9 to 11 and you don't regularly see your eye doctor, you're very, very likely to develop damage to your eye. Again, macular edema, retinopathy, bleeding, retinal detachment. I mean, you can definitely go blind from these, and that's terrible. And those are the patients that we see that have not seen docs for a long time. But again, over time, with heightened awareness, with earlier intervention, with better systemic treatments, with CGMs, insulin pumps, things that you're very, very aware of, we've seen those statistics improve dramatically. And I've got plenty of patients that go decades with very little evidence of diabetic retinopathy. And by the time they get to me, we have such effective treatments these days that I tell my patients, I'm going to protect you. You're not going to go blind from this. I'm not going to let you go blind from this. And I'm fortunately pretty lucky and successful in that regard. And with treatment, injections or laser or combination of the two, I think the statistics are actually pretty good in terms of preventing blindness.
Well, that's encouraging. It's certainly different from the old days where, you had a high percent of losing significant vision. So let's talk about some of the general themes of what causes diabetic eye disease and risk factors. So we're pretty much talking about diabetic retinopathy, diabetic macular edema, and I think, glaucoma might be a little bit different in terms of the risk factors, but are there any themes in these conditions of what can cause them?
Yeah, I mean, they're all vascular. They're all microvascular from our standpoint in the retina, and that includes glaucoma, which I'm not an expert in, so I don't want to opine too much on glaucoma. But it is a microvascular disease of the optic nerve as well. So the way I kind of think about it is that the retinal blood vessel, the vasculature of the retina, is sort of like a tree, right? If you were to look at the retina, you see all these red squiggly lines emanating from the optic nerve, just like looking down at a tree with a main trunk and branches kind of branching out into the tissue, which is a flat plane, the retina. Over years, you can develop damage to that vascular tree, starting with the smallest blood vessels called capillaries. As those capillaries are damaged, you get loss of the lining cells, so it's like losing the bark on the tree in a way. And you can get thinning of the walls and even little aneurysms, little outpouchings like balloons can form, and they kind of form all over the place in that tree and in all of the little twigs of the tree. And that's sort of how we gauge or grade diabetic retinopathy. As those aneurysms rupture, you can get bleeding in the retina, and over time, if that progresses, you get loss of blood supply to the tissue, and that's that snowball effect. So this all has to do mostly with duration of disease. So, newly diagnosed patient with diabetes, unless they've been undiagnosed for a long period of time, typically looks really good. And patients sent to me for a screening exam, if they were just diagnosed, often have nothing visible going on. But it was over the course of decades, even with the very best control over the course of decades, we do start to see those little hemorrhages and aneurysms develop. Aneurysms, again, if they're in the macula, which is the center of the retina, can leak, and that's what causes, you mentioned, diabetic macular edema. So
Well,
duration of disease is, oh, go ahead.
well, yeah. Sorry to interrupt. I was just going to say that the risk factors, you've already mentioned glucose control, and you've seen people with diabetes for decades with no eye condition. What, but what else can cause this? Because you just said that even duration of diabetes in someone that has had good control, you still can see the beginnings of retinopathy. So I'm curious, what are the other risk factors that why that would occur if the control's good?
Yeah, I mean, I bet you and I have very similar conversations with our patients. I'm willing to bet. So I think all of us doctors these days do, right? So again, duration of disease, glycemic control, those are number one and number two by a landslide. You can't do much about duration of disease. You can do something about glycemic control, and we thank you for that help. Things you can control as well. Weight, being at an ideal body weight. So getting out and exercising. Exercise alone can help, not having a sedentary lifestyle, just getting off your butt, getting out and sweating 3 days a week and run 3 miles. That can help. If you smoke, stopping smoking. There's nothing worse for blood vessels throughout the body, including the retina, than smoking. It's just one of the worst things that you can really do. And diet, which plays into glycemic control as well, but likely adopting sort of a Mediterranean style antioxidant diet can be very beneficial. Controlling any comorbidities, cholesterol and hypertension. Hypertension, if this is a vascular network set of pipes and plumbing, hypertension is obviously going to play a role there as well. Increasing the pressure in those pipes is not a good thing. That's the majority of the risk factors as I know it. What else?
No, I think you hit all the major ones. I've always been impressed, and people are surprised when I tell them high blood pressure can definitely cause problems with diabetic retinopathy. Well, maybe we can get a little bit more into the differences between diabetic retinopathy and diabetic macular edema. What are they? How are they different? And why do they commonly occur together?
Yeah, diabetic retinopathy is sort of the overall umbrella term of damage to that vascular tree in the retina. So just retinopathy, or it's really a vasculopathy or neurovasculopathy.
Those are big words, Nick.
I know, I
We
know.
got we
So
got neurovasculopathy. Say
so
that 10 times in a row.
yeah, I know. So any opathy is just damage to the tissue. So retinopathy is damage to the retina. Vasculopathy, damage to blood vessels. Neurovasculopathy, damage to the neural tissue, which the retina is the tip of the brain. So that's why the dysfunction, the visual dysfunction in patients with any form of diabetic retinopathy can really not mirror what we see. They can have vision problems, not see well at night, not see well in low luminance or low darker situations, even though we tell them they look great, and they're like, well, I don't see great, right? So they can have dysfunction that's not really visible. So if they're noticing that, be reassured that that can be normal. But retinopathies, when you develop those hemorrhages throughout the retina, if we see one hemorrhage in the retina, we call it retinopathy. An accumulation of those hemorrhages tells us the grading of that retinopathy. So if you have one, you start out at mild, non-proliferative diabetic retinopathy. Proliferation is referring to the growth of new blood vessels on the retina, which sounds like a good thing to many people, but it's not. If you develop proliferative diabetic retinopathy, it's little weed-like blood vessels, and that's what can bleed and even detach the retina. Within that non-proliferative grading system, there are 4 ranks: mild, moderate, severe, and very severe. And then you can progress onto that proliferative. So that's retinopathy. In diabetic macular edema, the macula is simply the center of the retina. If the retina is a dartboard, I like to use that analogy, the macula is the bullseye. And edema just means swelling. So swelling of the central retina. And you can imagine if you have swelling right in the middle of your vision, that can cause blurring and distortion of your vision. So macular edema is swelling, retinopathy is bleeding, essentially.
Yeah, the swelling, you can see why the vision gets all distorted when you try to look through it. And Well, do they commonly occur together or are they separate?
Yeah, they do occur together. So it's very hard to develop macular edema without any retinopathy. So the retinopathy typically comes first, but you can develop edema at any stage of diabetic retinopathy, even in the mild stage. We can be surprised sometimes when people can come in and have very mild looking retinopathy but have macular edema. But typically there's a correlation there with the severity of retinopathy and the risk of macular edema. And we often see macular edema mostly when you get into the more severe non-proliferative diabetic retinopathy stages.
Yeah, and as you mentioned, glaucoma is a different condition. And I can tell everyone listening, just make sure you get your eye pressure checked when you go to see the retinologist. And if it's persistently elevated, they will send you to a specialist, and there are eye drops you can use. Well, let's talk a little bit about, well, maybe we should talk about screening next. What are the recommendations for screening? Type 1 or type 2, newly diagnosed after 5 years? Because a lot of listeners, and I think you've seen patients, as soon as they get diagnosed, they freak out and they say, I want to see an eye doctor, but there really is nothing to see at that point unless they have some other eye condition.
Yeah, I mean, you probably know the screening guidelines better than I do because they're sent to me once they meet the screening guidelines by their more comprehensive care specialist. But from my understanding, any type 2 should be screened as soon as they're diagnosed with that because we presume that they've had underlying disease for longer, and they just more recently were diagnosed. Type 1, typically it's a lot of times people are sent to me for an eye exam, just a baseline exam, but I believe that even several years after diagnosis is typically okay. But you correct me if I'm wrong there. Again, they're sent to me, so I'm possibly less
Yeah,
familiar.
you're not on that end, but no, it's you're right. You're totally right about type 2s, and the official recommendation is after 5 years of type 1. That's when
Right.
retinopathy would show up, even if you had bad control. Well, what about this question? And I don't want the optometrists of the world throwing darts at your picture. Uh,
I think
with
they
you
do already, don't
with you
worry.
with you in the middle, not some swelling, but as you know, you go to a lot of places now, and I'm not going to mention names of healthcare institutions. But I can mention UCSD since I worked there. They send people to optometrists first, and then they screen, and then they send them to someone like yourself if they see something. And you know what? I don't feel that comfortable with
Yeah.
that, but I could be old fashioned.
Yeah, I mean, I think it all depends. I have some optometric colleagues that are amazing, and as sort of primary eye health uh, specialists, they're great. They're wonderful. I think it just really depends. You've got some optometrists that are really invested. They love what they do. They want to be involved in this medical side of eye care. And I would trust them with my own eyes. In fact, I go see a wonderful optometrist here in town, Dorothy Wong, who, she's amazing. She's absolutely outstanding. And then you have some optometrists that really just don't want to be doing that. They maybe would rather just specialize in prescribing glasses or contacts. They maybe they just don't have that passion. There's nothing wrong with that. But I wouldn't inherently be worried about optometry. There are some really wonderful ones. And I bet at UC you've got some great ones. I just don't know them. But you can always,
Yeah.
what you do, if you just ask me, just say, hey, is this a good eye doctor in optometry or ophthalmology? And it's not like every single ophthalmologist out there is the greatest
Yeah.
ophthalmologist of the time, right? We can be hit or miss too. My wife will tell you that I'm very missed, but um,
Well, it's like my old joke. I know this is a really bad joke. It's like adult diapers. It depends, and it's true. I think I think yours is a good answer. And I also like if someone has no eye disease cleared by someone like yourself, a retinologist, then I think yearly screen by a good optometrist is perfectly fine. And if it helps improve access, the most important thing is being seen. And then they
yeah,
also have the non midriatic photographs that they take at certain clinics, send them into specialists like yourself and your old partner, Dr. Paul Tornamby, may he rest in peace. And he sort of pioneered that kind of screening, which is excellent way to go.
yeah, no, I love that. I mean, and you bring up a good point because I love when patients are sent to me right off the bat. At least I can kind of see them. I know some retina specialists feel like they don't want to be inundated with mild non-proliferative diabetic retinopathy. But I like patients being plugged in, because if time goes by and things do develop, I want them to be able to just call and say, I'm an existing patient and I'm having vision issues and I need to see London or whoever. I think that's a great way to go. And then the non-mydriatic screening. So we have something called OCT, which takes a cross section of your central retina at like a cellular level. It's beautiful. And then a wide field photograph, Optos being one of the big companies for that. And those are great screening mechanisms. You can look for the anatomic changes that you can correlate with any visual symptoms, and you can send them securely to a specialist like myself. I highly encourage optometrists and ophthalmologists to do that. And I find it to be a great way to help patients get the care that they need, but also not see me if they don't need me.
That's funny you say securely. I don't care if they see my naked eyeball, okay? Other parts of my body, make it secure.
Yeah.
Yeah, well, Nik, let's talk about the different therapies. Let me tell the folks a little bit about my history, and you can use that as a jumping point to talk about therapy. So, I got diabetes in 1970, and I developed diabetic retinopathy when I was at the Joslin Clinic training only 15 years later. But at the time, they only had laser therapy, what they call photocoagulation. And I got zapped up to 2,500 times in each eye. And I understand that preserved my vision, but it did knock out my night vision and my peripheral vision. And as I've learned from you, it's not really the first line therapy anymore. And then into the injections, and I'll stop there and let you take it from there.
Yeah, I mean, the whole point of this is to decrease the production of one particular cytokine, one chemical inside the eye. And I know you love these fancy names, but it's got a name called VEGF, or vascular endothelial growth factor. So VEGF, as we all call it, is sort of like a fertilizer for bad stuff inside the eye, both these blood vessel growth with the proliferative diabetic retinopathy, as well as leakage of blood vessels. VEGF causes both of those. And it's produced by sick, or what we call ischemic retina that doesn't have enough oxygen. That ischemic retina is producing this chemical in very high concentrations, and the chemicals just highly concentrated in the eye and causes those problems. So to reduce that production, you either destroy that ischemic tissue, that's that ablative treatment with laser, or you saturate that chemical with a molecular sponge, which are the injections that you refer to. We have what are called monoclonal antibodies that will essentially absorb all of that chemical for a month or 2 months if we're lucky. And you got the laser, and the laser, it's like bombing the battlefield, right? You kill everything, right? You kill good and bad, a lot of friendly fire there. So it's sort of the older way that we used to treat the proliferative form in particular. And it does, of course, decrease your peripheral vision and your night vision. We have a lot of rod photoreceptors out there. And it's not, I wouldn't say it's, totally second line treatment. It is for me, but some people still use pan-retinal photocoagulation a good amount. It does protect patients. So if I have a patient that I'm worried about their ability to follow up, right, and we know that there's a fairly high percentage of patients with diabetes that just for various reasons can't follow up. They move, they get sick, their car breaks down, who knows? But if you've done laser, then they'll be protected. Whereas if you just do these injections, then they wear off. And if they don't come back, then you're in big trouble. But the injections are easy. They're medicines that are injected into the eye starting off about every 4 weeks. And then we try to do them as infrequently as we can. And with those injections, we see a beautiful reversal of most diabetic retinopathy, and macular edema typically responds really well as well. And the retina ends up looking beautiful without destruction from laser. You can see things kind of melt away and get better.
And once you say the earlier you get your hands on like early mild retinopathy, the more effective it is at stopping it in its tracks. Did I say that right?
No, it's interesting. You're right. The earlier you intervene, the better people are likely to do in the long run. But we actually see the greatest reduction or reversal of retinopathy in patients who have more severe stages. So sort of the severe stage of non-proliferative diabetic retinopathy and PDR. In fact, when we enroll patients in clinical trials, they require patients to be in those more severe stages of diabetic retinopathy to show that impressive, 70%
Yeah.
reversal within a year of their retinopathy. It's really impressive. Whereas the mild stages, there's a ceiling effect, right? You do have a reversal, but you're already so good that we don't see quite as much.
Yeah, Nick, I think you were not hard enough on photocoagulation, the laser therapy. For all you listeners, I would suggest this. Find a good retinologist, make sure you can visit them as often as they suggest, and go for the injections, because I think it works better and you don't get loss of peripheral vision and night vision. And, Nick, if you got diabetic retinopathy, you'd be going for injections. I know that.
In a heartbeat. I mean, it's terrifying, right? You tell somebody, I'm going to stick a needle in your eye. It's like a childhood nightmare, but it really is pretty benign. And every patient leaves with a pretty big smile on their face at how painless it was. One really cool thing, Steve, is that these injections, I hope someday are going to be sort of a thing of the past. And you probably know this, but we're working on gene therapy for these to replace these injections. So we can actually use gene therapy. It's in a clinical trial right now that we've been involved with for years. And we can actually engineer the tissue of the eye to become a biofactory to produce the protein that is this medicine. So this monoclonal antibody I mentioned, we can get the tissue of the eye to actually produce it through gene therapy. And that's
Wow.
real. That's happening.
Yeah, that's amazing.
In those trials, it's cool.
Now, what happened to me was, which is sort of another form of therapy, I didn't respond as well as you liked to these VEGF drugs.
Yeah.
And then we went to some steroid injections, which did help. And that went and ended up needing cataract surgery on both eyes, which is quite easy. But it is a form of therapy that when people don't respond, I can be a retinologist almost.
Yeah, I think you definitely could at this point. You could be an anyologist if you wanted to be.
Proctologist too, even.
Probably, I think you could. I wouldn't put it back. I'll ask Jeremy about that when he's back from. So yes, second line treatment after anti-VEGF antibodies or anti-VEGF therapy include corticosteroids, and that's because I mentioned that VEGF is the main molecule that's produced in these eyes that are ischemic, right? The concentration of VEGF goes through the roof, but there are plenty of other what we call cytokines or bad actors, bad molecules inside the eye, different inflammatory mediators and different interleukins and other molecules that are also upregulated and are not at all affected by the anti-VEGF injection. So in a patient where you're treating them with injections and you're not getting anywhere, that edema in the macula just stays stubborn. You have to start thinking about second line treatments, right? You can go through the different classes of medicines that we have, the different quote unquote strengths that we have of drugs, often dictated by insurance companies these days, unfortunately. And you can go to second line treatments. So corticosteroids are that second line treatment, and they will dampen all of those other cytokines, all of those other bad actors, but they cause cataract progression if you haven't had cataract surgery. That's almost a given, and they can cause high eye pressure, and so we monitor for those things. But they, in select patients, they work great. I've got wonderful results with some of these very sophisticated these days corticosteroids.
Yeah, you implanted a little Illuvian pellet in my eye, so that slowly released the steroids for a couple of years, and that saved me the injections. So there's all kinds of fancy stuff, but I love the idea that someday we may not need it. Well, Nick, my vision's better than it was an hour ago. You've encouraged me, and it's so great. It's so great to talk to you. I'm going to give you the last word on some of your summary of your points, and my last word would be just make sure you get your eyes screened minimum once a year by someone that knows what they're looking at.
Yeah, I mean, that's the same last word I would have is just get them screened. Take the time to get into really any eye doctor, but the higher a specialist you can get into just for reassurance, the better. Take the time to make that appointment. Get in. It's an annoying day where your eyes are dilated and you get a bunch of photographs and you sit around a clinic for a few hours. But if you do that once a year, and you follow all the other advice that we talked about in terms of exercise, weight loss, glycemic control, blood pressure control, a lot of patients do great. And if you have something bad that does develop, you're not going to fall off a cliff. We have great treatments to prevent blindness and vision loss. So be reassured.
Yeah, well, thank you, Nick. And one thing I did want to emphasize is that there are no symptoms of diabetic eye disease in the early stages. And that's why screening is so important. It's not like you get a pain in your eye and that's retinopathy. So I wish it did cause pain in the early stages. People would go see some people like yourself. Well, Nick, thank you so much. And for all of the listeners, yeah, we did miss Jeremy today. Make sure you go and see the list of other podcasts and, of course, our website and all the Facebook. Like us, love us. We're on TikTok, Facebook, Instagram, YouTube, and LinkedIn. My younger daughters would be so impressed with the way I rattled off that list of social media sites. Nick, thank you for taking the time out of your day and go save some more vision in your patients.
Awesome. Steve, always a privilege and an honor, and love hanging out with you. Thanks so much.
Okay. Thank you, Nick.